To do is just theme some of these questions and then ask our panel of experts their thought on them. So when I went through all of the questions, there is many questions about the somatostatin analog, especially the effectiveness between, or the difference, or the superiority or inferiority between the two somatostatin analog. Is there a class effect? Is these drugs equally exchangeable, or one better than the other? So we have a lot of people up there that actually would have a thought on this, and I'll tell you my thought. Of course, always have to tell you my thought because I'm so, but there's a lot of experts up there that I'd like to get different input. For example, Dr. Metz, do you have anything knowing the different study between PROMID and CLARINET? Reviewing those studies, do you have any thought about which one is better? Is that fair to say they're the same? Is it fair to say one is better than the other?
Well, based on the evidence, it's impossible to really compare one with the other until there's been a trial comparing one with the other. So until you've seen any kind of head-to-head data on any intervention, you really cannot say one is better than the other. That having been said, anyway, I think that these two agents work very, very similarly, and I do think that the effect is a class effect, and I would say they really are relatively interchangeable. Now, we've had lots of experience with many other drugs that are in this same sort of situation, and the ones I personally know the best are the proton pump inhibitors. Many people, I'm sure, a bunch of people in this room are on proton pump inhibitors as well, so those are acid suppressive drugs, Prilosec, Prevacid, Acifex, Nexium. And I would have the same kind of answer there, is that I think there is a class effect and they're very, very similar, although in the individual case there might be differences patient by patient.
Well, I think before we talked about, before I summarize some of my thought, do you, as a caregiver, as a nurse, Katie, giving the injection, right, Katie? You're Tina, I'm sorry. Giving the injection, do you have or seen preference of one versus the other?
Given the injection, it's given in both. They're both given in the same area, so not really. It's not. There's not really a difference. Most of the patients are reporting the same type of injection site reactions and things like that.
Yeah, they're both pains in the tush.
Pretty much.
Having had both, yes. Although I do think there are some study, a little bit of study in that if there is a blown injection for one, if an injection isn't given correctly for somatostatin, that could be a, 8,000, 10,000, whatever the price of that particular thing, lost dose, whereas if the injection is given incorrectly in lanreotide, it's still going to be bioavailable. So I think there are some things that to consider as well.
I'm sorry there's not another medical oncologist, but I'm sorry if I put Dr. Nissen on it. Do you have any thought about one versus the other?
I really don't. I don't inject them, and I talk to patients who are on them, and I think that's a class effect, just like Dr. Metz said. But I do have a simple logic, and that is that if one's not working, try the other.
Yeah. And if one's working, stay on it.
So spoken like a surgeon, actually. Very logical, very practical. I actually do have a thought about it, actually. For a long time, both somatostatin analog, both of the agent has been developed as an agent to give for control of symptoms. There is no study that assessed them as an anti-proliferative or anti-cancer or disease control. The problem is that I don't know what is the dose required to have disease control. So in order for us to compare one or the other as far as the effectiveness or superiority or inferiority or equivalence of one versus the other, you have to compare. So the answer to that question is that we don't know. Both study, CLARINET and PROMIT, study in a very different cohort, different subgroup of patient. The PROMIT study, where they evaluate neuroendocrine tumor for, somatostatin analog, particularly exactly sandostatin LAR, it was done in midgut with patient with symptoms. And there's a little bit different outcomes than the CLARINET, and it's a smaller group of patients, whereas the CLARINET evaluate patient with some somatulin or lanreotide in a broader group of patients that has no function. 96% of those patients has no disease progression, meaning they have an indolent disease, and majority of them don't have prior therapy. Whereas the PROMIT study, many of them, actually all of them, we don't know what their status is at the time they enter the study. So I think, to be fair to the question, and it will go down to Dr. Nissen's logic, is this: until you have a data, you cannot say which one is better or which one is not better, or they're the same. I would say that the class effect comes about in the sense that the side effect, the mechanism of action for symptoms control, is the same. The problem is we don't know what the difference is in anti-proliferative or anti-cancer effect is. So the next question that is common in these set of questions is, if you're on sandostatin LAR and you have stable disease, now with the FDA indication, should you for lanreotide, should you change over? So my answer to that, or actually if anybody there have an input, I would leave it up to them before I put my input. So any thought about being on sandostatin disease control, symptoms control, now with a new drug, should you change it over? It's a shinier, prettier, newer drugs on the market.
My general approach is don't rock the boat if things look good. So if somebody's on one or other agent, tolerating the agent, and apparently having a response, I would not switch. I certainly agree with the comment that was made. If one doesn't work necessarily, it's reasonable to consider another. But I don't want to just change something because of an FDA approval of one agent versus another.
Any other
And
thought?
let me just say one other thing. I just noticed a total calm has come over this room since the last speaker, myself included. I think she was spectacular. And I want to come back every now and then and have one of those.
So, Giovanna, do you have?
I just wanted to comment. Let's say things were reversed and sandostatin was the new drug that just got FDA approval. I've been on lanreotide since the beginning of the trial, so it's been 5.5 years, and I have stable disease. So if there was a new drug, unless there was something else about it, I think I would want to stay on the drug that's keeping me stable.
Yeah, so exactly. I think if the disease is controlled, so I would approach, again, symptoms control, disease control. If your disease is controlled on whatever drug that you're on, whatever somatostatin analog you're on, I would continue therapy as long as you're tolerating it well. The reason to switch over the other sometimes has to do with, most of the time, has to do with symptoms control, because the reliability and the consistency of getting the drug sometimes is different on whether or not you actually get the shot from IM or sub-Q based on many factors. So that is the difference between the two. I think you have to talk to your doctor why you change over one or the other. But disease control, if you're stable, both of symptoms and disease, I would continue. If you have disease that is stable but symptoms is worse, you have to ask why the symptoms is worse. Is it because you cannot get reliable dosing, or is there a resistant or an antibody that develop against that particular compound that you're on? Both drugs are different by about 80% or so. So molecularly, it's different. The other thing to be cautioned about is nobody knows what is the mechanism of action for somatostatin analog to control cancer. That's the other question in here. Why does somatostatin analog work in controlling cancer? There's only proposed mechanism. There's no definitive proof or shown in data long-term or not, how it works as an anti-tumor. Dr. Metz, you being the most brilliant on there as far as science, do you have a thought about how one work or the other?
No. I don't, I'm afraid.
All right, we got lots.
So actually, the proposed mechanism is directly is through the somatostatin receptor subtype, and then indirectly there's modulation of the insulin growth factors and the VEGF growth factor. Both of these are growth factor. That's why you see patient developing hyper or hypoglycemia, insulin growth factor, and then the other one is patient sometimes can develop hypertension as well. That's through probably the VEGF indirect effect. Now, if those are the reason why you have anti-tumor effect, whether you have the somatostatin receptor on octreotide scan or not, it's not clear, but we do see patient who has a negative or a variable uptake on octreotide scan and still have disease control with somatostatin analog. You would think that, yeah, the indirect, the other mechanism is still to be elucidated, but it's probably that mechanism and not through the receptor. So changing gear a little bit, I think one of the questions here is what are the complications, especially blood sugars complication on somatostatin analog? And anybody there want to talk about, did you have any problems on lanreotide, Giovanna?
I have not. No, I have not had any blood sugar issues.
And then you have both. Did you have problems with one versus the other?
I already started out with blood sugar issues, so it's hard to tell, and I was able to control under both. So I couldn't really tell a difference, although there may be due to the time to which they get to stable state in the bloodstream is different between the two drugs or the two administrations of the drugs.
So one of the questions is hemoglobin A1C being 6 or what's not. What do you do about monitoring for diabetes or the onset of hyperglycemia? I think that is a question that it's a practice question that we don't know because we don't have long-term consistent practice. But in my practice, every time I see patient for restaging, I actually do measure a hemoglobin A1C if they're on somatostatin analog. I think that's important to measure. The other thing I do measure is thyroid function test because it does changes the thyroid function in whether they already have existing hypothyroidism, whether dose is adequate or not. That's something I do monitor because you guys are on somatostatin analog for most of you lifetime. And so unless and until we know exactly how it works, these are the things that's worth monitoring. So any other thoughts about that I didn't mention?
I will say my thyroid medication went up.
Yeah, and it's actually you have to be careful because it's interference with the measurement or is it actually changing the function of the thyroid function? So there's, I'm gonna address this in a little bit. Dr. Metz and Ron, I think there are some question about the, okay, so the difference in immunotherapy, the difference between immuno checkpoint versus vaccine kind of thing. Can you elucidate the difference in layman term?
I'll just respond to one thing I heard questioned afterwards, which was, I think, it relates to vaccine, this whole idea of a virus, what they call an oncolytic virus, that somehow we would have a virus that would eat the cancer kind of thing. This has been a concept that is not immunotherapy, so let's just distinguish those two. The immunotherapy really is about some of the things that we were trying with Stanford to really address these checkpoint inhibitors so that the immune system, remember those little guys, can see through the disguises and actually do their job vis-a-vis the cancers, and then we're talking about CAR T cells, which was the other piece. The viruses, oncolytic viruses that could eat cancer, if you will, have been around. That whole concept has been around for decades, almost a century now. So I know there was a lot of excitement because a reporter took the cause of this oncolytic virus that was in the freezer in Sweden and trying to liberate it and raise money, and then a gentleman who later passed away had donated a lot of money to that research. So that's, I think, what a lot of people have heard about. And as I said earlier, now that they've got it out of the freezer and they're trying it preclinically, be great if it works. I have not seen any data, I don't know if you have, Dr. Metz, to suggest that there was anything in particular about that virus that was pertinent to neuroendocrine tumors as such. We actually funded a project before I started at Caring for Carcinoid about 5 years ago at Johns Hopkins, trying an oncolytic virus on, I believe it was pancreatic neuroendocrine, and it had very limited results, and we did not decide to pursue it because it just did not seem to, the data didn't seem to bear continuation. And I will say from at least some of the medical advisors and scientific advisors we use, when I asked that question, when this whole international attention was being paid to the Swedish virus, they were kind of skeptical.
Yeah, so let me just add that having an immune response is essential for everything. We're all getting exposed to all sorts of things all the time, and your body has this messenger system that's set up there that, oh, this is foreign and we have to get rid of it. So it can get overactive, and then you get autoimmune diseases, and it can be underactive, and then you get sorts of opportunistic infections. Whenever any kind of abnormality develops in the body, there are all sorts of checkpoints that sort of control that. And we really don't know much about all this wiring, but there certainly are areas that you can potentially impact upon, and such as the checkpoint inhibitor drugs, and I'm certain they're going to have a role to play. The CAR T cells idea, I'm very hopeful are going to have an effect in terms of solid malignancies in due course. But there's no definitive way we're going to know how any of these things are all going to play out, and we're going to have to learn as we go along with this. I think there's a great future for immunotherapies. I think in terms of renal cell cancer and melanoma, which are the two that are sort of the flag-holding, proven disease states that respond to immunotherapies, there's been tremendous, unbelievable progress made. And we're learning more and more about these cells. For example, when you have a solid malignancy and you shed cells, those cells get into the bloodstream, find their way to metastatic sites, either through the lymphatics to lymph nodes or through the bloodstream to the liver. We know that goes on for years and years before you actually can identify the actual metastasis with imaging. And actually, there's been some great work that's come out of the University of Pennsylvania and now at Michigan by some of our immunologists, cancer docs, that have shown you can measure circulating cells in the body even before there's any evidence of a tumor at the primary site. So we're learning lots and lots about all of this, and I think that immunotherapy has definitely got a role. It had a big heyday early on, and there were vaccine trials for all sorts of things. Let's induce the immune response to get rid of the cancer. But it was the checkpoints that really were limiting it from being effective. So there's lots to learn, lots to go with, lots to grow with. I think it's early days as to really how it's all going to work out.
Right, but let me try a quicker question, and it's just no. Viral therapy and immunotherapy, are they different?
Very.
That's it. So it's different things, they're not the same thing, they're not substitutes.
Yes, thank you for clarifying the answer. The other question I think on here is that, is there a role for immunotherapy for high-grade neuroendocrine tumors? I think this was asked specifically to Dr. Metz or Ron.
Very difficult to answer that question. I don't know the answer to that question. I could give you a whole long spiel, but I think the truth is, from my personal experience with neuroendocrine tumors, is that we are really focusing on the lower grade tumors, G1, G2 tumors. A G3 tumor, once identified in my personal practice, I go for an octreoscan scan. Is it positive or negative? If it's positive, I think there is a role for somatostatin analogs. If it's negative, there is no role for somatostatin analogs, and beyond that, it's an oncologic approach. So I don't know the answer to that question.
Actually, there's an answer for that somewhat. In the last ASCO that I attended, there are high-grade neuroendocrine tumor are treated like small cell of the lung. There's actually data that suggests that immunocheckpoint inhibitor actually does play a role in small cell and some part of the lung, squamous cell, and so on. So I think there will be a role of immune checkpoint therapy immune checkpoint, not oncolytic virus. That we haven't seen that yet, but the data for small cell may be coming about in the sense of immune checkpoint. The thing to remember is here, immune checkpoint therapy, where you lift the inhibition of the immune system so that it can attack your cancer, you are also open the gate for other secondary problems, which such as autoimmune disease, rheumatoid arthritis, lupus, other things. Those are the immune system that can attack your own body, essentially. So long-term complication can be ripe, and we don't know any of that. So my take on things that are new, the risk and benefit. What am I going to gain? And will I lose anything? And what is the risk? Is there enough data, risk and benefit? So,
Dr. Phan, let me just say, just to go along with that and to maybe temper our excitement, although the expectations are so high about immunotherapy, for those of you who watched the Emperor of All Maladies on PBS, I'm sure many of you did, there was a piece that was not in the Carl June short version that did appear on the PBS special, because at one point, Emily Whitehead, the young girl there, was in serious trouble, and it was only when Dr. June, actually because of a personal experience with his own daughter's treatment, realized what was the drug that they had to administer to...
So if you remember back, I was talking about how these T cells make lymphokines. So you've now got all these cells running around damaging and finding tumor cells and bumping them off, but they're also making all the other things they normally make, which is this whole storm of her fever that they spoke about, her fever. Right. She had tremendous blood pressure problems, and she was in ICU. I think they actually ended up even intubating her. I mean, she got really, 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 really sick. And it was an IL-6, if I remember. I think it was an interleukin-6, which is one of these products that mediate inflammation and the fever response. And he had an antibody in the lab, and they actually utilized it. And that's sort of becoming, I believe, one of the standard approaches amongst the CLL and ALL patients now that get CAR T cells, is that they treat them up front with this. So it's very important to realize that, as Alex just said, I mean, there's pros and cons to all of this, and there certainly will be an autoimmunity response when you block the immune response. So you have to realize that we're learning, we're growing. There's great promise for this therapy, but we've got a ways to go.
And we couldn't be more excited about the Stanford trial, but it's a baby step, and it's a small trial. It's going to be very carefully administered, 5 patients at a time, with a lot of checks and balances and monitoring to make sure that we do everything to both keep people safe, but also learn from what the response is, what else needs to be done to keep it safe.
And also one quick comment, I mean, these are very exciting. As a nuclear medicine practitioner and researcher, I can tell you that we have many times capitalized on this science of immunotherapy and have been able to actually create a diagnostic agents that can be actually used for diagnosis as well as therapy. This is very exciting.
So I actually have 3 more things to summarize all of this, because we are running out of time, and I'm sure the panel will be here to answer your other question. I'm sure you can email me if you have question. And so one, Dr. Nissen, is it beneficial to remove the primary site if you present with synchronous metastasis? For example, if you have mesenteric metastasis, mesenteric disease from the midgut with liver metastasis, or metastatic lung carcinoid with other disease, let's say in the bone. Is there benefit in removing the primary?
It's a frequent question, of course. We have generally approached it that the benefit is primarily in the local effects of the primary. We often get asked, questions like, can metastases metastasize? Should you remove the primary to prevent further metastases? And I think those are largely unknown, but we approach it simply, if you're at risk for local complications, then I think there is benefit. Remember, in the bowel, the complications are bowel obstruction and bowel ischemia, and of course symptoms along with that. We had a comment earlier about short gut. So I think you made a comment that, or somebody made a comment that the short gut is the work of surgeons. That perhaps took too much bowel. That's possibly true, but it may be the tumor as well. And so part of the reason to take a primary tumor out early on is that as it grows, it threatens to compromise more and more of the mesentery and more of the bowel. So we generally would say that if you have at-risk mesentery or at-risk bowel, that there's benefit to taking the primary tumor out. I don't know of any oncologic benefit if you have extensive tumor burden in the liver. I really don't. I mean, it's a common question. It's one that I do not know the answer to. We treat it as trying to control local disease, local symptoms, and local issues, not so much because of a tumor metastasis relationship.
I think that's true. Your disease can be controlled, but if you have symptoms locally, whether it's bronchial obstruction with a lot of wheezing or mesenteric pain because of lack of oxygen or carrying of blood to your rest of your bowel, I think those things should be resected first. The other thing is also true with the pancreas. If you have distal pancreas, sometimes you run into portal system with hypersplenism, which prevent you from getting therapy if your your platelet decrease. So I think there is benefit, and that's why this is a decision that cannot be made on every single person who comes in. I think that is a decision you need to make individually with your group of doctors. So shifting gear a little bit, I'm going to ask Dr. Delpassand, is there any pros and cons of earlier treatment with PRRT and or versus being late treatment?
Sure. We generally believe that the therapy is more successful if it is done at an earlier stage. And typically in previously heavily treated patients, we have more complications after PRRT. So we try to get the patient, we would like to get the patients at the earlier stage rather than at the time that they have received multiple courses of chemotherapy, their bone marrow, is not sufficient for this kind of therapies. There are kidney problems as a result of prior therapies, etc. So, and of course, it's known that if the tumor burden is higher, it's going to be harder to achieve really the clinical response that we are expecting from PRRT.
And I think there's different opinion waiting to be answered. Dr. Metz and Dr. Nissen, you have other thoughts about early or late PRRT?
I have a personal bias, but unfortunately I have no data to support my personal bias, and that's really the important point to make here. There was a time there was no therapy for neuroendocrine tumors. That was a problem. Then there were some therapies. That was great. Now there's lots of therapies. The big problem right now is we don't have an algorithm. We don't know the right way to go. Each patient is different and each situation is different. Some people are doing wonderfully on combination chemotherapies, whether you get a synergy with a radiosensitizer or not. Other people are going straight, as we've heard today, to radioreceptor therapy up front. My general approach is debulk as much as you possibly can up front. I think I have a bias that if you can reset the clock, it's the best thing to do. The next step is, I think, somatostatin analog therapy, both for tumor growth and for symptom control. And beyond that, I don't really know definitively in my heart of hearts which is the next way to go, although I have a personal bias in favor of considering PRRT, just because I think it's a systemic approach and it's very, the numbers just show the fact. But there has never been a head-to-head trial, and we don't know the algorithm. That's the unknown in this disease.
Dr. Nissen?
I think it's an exciting time. We finally have so many things to choose from, but I also think that in some ways what we've been doing has actually been working pretty well. And what I mean is, as you said, control the primary, suppress the tumor with somatostatin analogs, maximally debulk, especially for liver-related. And of course, debulking can be surgical and hepatic arterial and ablative and all those things. I don't know where PRRT fits in the paradigm, but I'm nervous about applying it to liver-dominant disease when we have so many other great liver tools. I'm open to data, and I'm open to seeing that data and changing our paradigm. But right now, I would say that the approach of control the primary, suppress everything else, debulk the liver, and save PRRT for systemic disease or progression or a change in biology. That's kind of how we approach it, but we'd love to see data to tell us that there's a different approach. But what we've been doing works remarkably well. I mean, one of the debates was that if you've maximally debulked and then you have sort of periodic recurrences. How aggressively should you go after that? Should you keep picking away at a 1 year and a 2 year recurrence? We don't know the answer to that either, but we have done that because we have the tools to do it. That doesn't mean it's right. We don't know what else to do. And as time goes by and PRRT data matures, we'll learn what to do. And we have been caught in the trap of, all we have is a hammer, the whole world's a nail, whatever that analogy is. But it's changing. It's changing in real time right in front of us. And I'm very excited to see the data tell us what to do after we've done our initial work.
So I think that falls on us as a physician and researcher to provide those data. But I think to be very cautious about approaching something that doesn't have data with either, biases or whatever not. I mean, we do have a hunch what should be done, but you should expose that hunch to discuss about that in the tumor board so that you can have a balanced view and have other people's input on there. So before I end and leave, I just want to ask this. I think there's a lot of question in here about how you approach life with a chronic disease. I just go around up and down the table and just say, if you have to tell your patient with a neuroendocrine tumor, well differentiated, whether it's small bowel or pancreas, that is metastatic, synchronous metastasis at the time of diagnosis, they have metastatic disease at time of diagnosis. How do you tell your patient to live their life? What is your best advice? And going from, I'm going to pick on you, Dr. Metz. How do you tell your patient what is the best advice for them to live their life?
Yeah, ultimately it's living your life as opposed to suffering through your disease. And it's hard and easy for me to say and very, very hard for patients to do. But it really is, what I actually tell many people, I have a couple of sayings. I don't treat numbers, so I don't treat chromogranin A levels. I treat patients. We are hopefully all going to grow old together. You will have the disease, I won't necessarily, but we'll grow old together. And I think as time goes on, I'm getting older and grayer as we move along, and my patients are walking and saying, oh, you've changed in the last year. So that's always a good thing. And the third thing, which is I think really the absolute hardest, is try and forget about me between visits. Although it's terribly hard. I mean, and that's why this last session was wonderful for me. I'm in a different space now from where I was a little earlier. I can see I'm talking slower and more relaxed. I think we need to be able to do that. The point is, come, handle it, sort of sit through the office, make a decision till the next time, and then try and forget about me for, is it 3 months or 6 months or a year, whatever it is between the visits that we're on at this stage. Very, very, very hard to do.
Very wise. Actually, let me have Ron talk. You're going to advise Ron and Dr. Mailman. Mr. Mailman.
My father was Dr.
Josh.
Mailman. I get confused.
Actually, if you have to tell that to a person, a patient, you already said that in your story, but just succinctly say how should you live your life besides those words that you have said.
Yeah, besides saying enjoy every sandwich, it really is take a deep breath and learn what you need to learn, but then go live your life. And you need to be living with, not suffering through. I completely agree with Dr. Metz. There are things that need to get done, and then once you get through them, we want to have more life, not more stress, and that's what we need to go through, and that's what I counsel anyone who talks to me, as they know.
Ron, you're next, and then everybody will have a say.
Okay.
So we've all heard a lot from some incredible patient leaders here today that I can't improve upon. The stories that Giovanna and Josh told inspired me, as I'm sure they inspired you as well. I would just make 2 points. One is, remember the caregivers in the room, the wives, the husbands, the boyfriends, the moms, the dads, the whatevers. They're on that journey with you. They're an amazing source of support, but you also need to make sure they take care of themselves, and you can help them with that. And I think what I hear from patients is that helps them too often. The other thing I just want to say, because I was saying to Giovanna when I was in the back of the room as the afternoon session was starting, we may be a small group that there's not the information out there and all the kind of standardized treatments that some other cancers have and all the attention they get and everything else. But maybe because of that, I'm not so sure how many patients in other cancers have what we have here today. I mean, when I watched you all talking to each other, the kind of exchange with these folks here and the thousands of others that Josh pointed out that are really focused on this set of diseases, how many people get the opportunity to really talk to clinicians and hear them talk back and share their uncertainties as well as their hopes and dreams and maybe even meditate together a little bit? This is a very special thing here, and I just feel very privileged to be part of it, so thank you.
So Dr. Delpassand.
A couple of things, I guess, we are running out of time. Number one, I tell my patients that each patient is different. You need, you are different than other patients that you have talked to. So this is your journey, and you need to basically exactly where you are standing. And number two is that I see two groups of patients. One that approach this disease with a very positive attitude, and the other ones that they don't feel that there is hope. And one thing I can tell them that in my practice, I have seen different stages of diseases, and I don't have a randomized trial to tell you, but the one with the positive attitude, across the board, they do much better than the ones that they don't have a willingness to fight. So this is my advice, and tell them that the positive attitude, I can even give a scientific sort of rationale for that. It's going to increase your immunity. Immune system failure is one of the theories that we have for developing cancer. Therefore, your positive attitude, do the things that you really like in your life, try to get away from the stress. All these things are going to help other therapies that we have. All of us, we are doing different things, but when your body helps with the process, with the disease, nothing can substitute that.
I'm going to run, and I'm going to let the rest of the panel talk about their advice. The only thing I say is that trust. You have to have trust in your provider. So that is a relationship you have to build. Your physician, whoever's your champion. If you don't have that trust, you're always going to feel like you're sitting or standing on quicksand. So if you have that, that is the best relationship to get you.
Thank you, Dr. Phan.
Thank you, Dr. Phan. Safe travel. So I'll say something that might be a little surprising and almost feel contradictory, but I would say live your life with compassion. And the reason I say that is because not that I love having this diagnosis, but there are so many things that have happened in my life that never would have happened without it. And I remember after surgery, just hobbling my way across the street, and I didn't really look sick, but people started honking like, hey, come on, get a move on. And, it just made me realize you never know when you're standing next to somebody what they're going through, and everyone got their something. And it's really opens me up to understanding what it's like and having compassion for other people. So I think that that's something that this disease has taught me. And it's helped me cope myself with having that situation.
I don't know that I have great words of advice. I have a few thoughts. My first thought is that I think we tell people not to live scan to scan, but then we get too many scans. I know we're guilty of this at Cedars. We get too many scans, and I think we need to somehow, perhaps through data, perhaps through restraint, get fewer scans. Second thing is, I think as Alex said, you've got to find a team that you really trust, and if it's not at this center, find it at another center. Obviously, each center wants to be that team, but you've got to trust that team and at least several of the team members. The third thing I'd say is, and this is probably more to other doctors that don't see these patients that often, is to not be afraid to form friendships. Some of my dearest relationships in medicine are with this room. I've known people for years and in some cases decades, And it's a really, really special part of my own life. And I've had meals with people. They know my kids, other things. And and I guess the fourth point would be that I'm inspired by you guys. I'm learning from you, and I don't know that I have great words of advice. I need your advice. And as you come to see us and you tell us how to take care of you better, your advice to us is incredibly important. How to help us advise other people, and that's why these conferences are so important. But I feel like I'm learning as much from these years and many, many year relationships as advice that I can give. So thank you.
Just a couple of things. Don't always assume that every symptom or side effect that you are having is related to your carcinoid. Every day you tell me all these things and I go through your list of medications or whatever, and I'd say about 50% of the time, half of what is going on has absolutely nothing to do with your carcinoid. Another word, I want to second what Dr. Delpassand said about hope. I've been an oncology nurse. This is going on my 24th year. And I have no data, as he said, to back it up. It's only personal observation. I've seen stage 1 breast cancer patients considered curable go, I have cancer, I'm going to die. 6 months later, they're dead. I've had patients come in and it be admitted to our unit that are chain stoking, in other words, the death rattle. They're breathing, that I think they're not going to make it through the night, and I'm going to be sending them to the morgue before I walk out of this place in the morning. 6 months later, they're walking out of the hospital going, love you, you coming to my birthday party? You know, it's next month, and things like that. And the only thing I can think that's the difference between those two patients is hope and their attitude. So you got to stay positive. If you get it from each other, if you get it from us, if you go to the support groups, whatever you do, you have got to stay positive.
Aren't we lucky having Tina give us our injections every month? So I want to thank everyone for being here today, and thank Ron Hollander and Caring for Carcinoid Foundation for this amazing event today. We promised Cedars we'd be out of this room at 5 o'clock. It's 5 o'clock, so we're welcome to linger outside in the lobby, but if you could help us exit this part of the auditorium. And thank you so much.
Drive safely.